Welcome back to Pharmacology with Dr. Sokolow, and this is another module on the drugs for pain. And we are going to switch to the NSAID and acetaminophen. So what are the NSAIDs? So they are the non-steroidal anti-inflammatory drug. And how do they act? They inhibit the cyclooxygenase. So cyclooxygenase is an enzyme. So if you remember from your winter quarter, this is a different type of target. This is not a receptor. This is an enzyme. And so the enzyme cyclooxygenase, there are like two types. You have Cox1 and Cox2, and they are involved in the synthesis of prostaglandin, and some prostaglandin has an inflammatory effect, and some other just work in the function of certain organ. And so the NSAID will inhibit this cyclooxygenase, so the enzyme that converts arachidonic acid into prostaglandin and their related compounds. So there are two different COX enzymes, two families. You have the COX-1 enzyme that are constitutive in most tissues. So they are protective, for example, in the stomach. They support the renal function. They promote the platelet activation. And you have the Cox2 enzyme that are induced at the site of inflammation by cytokines. And so this is the target that we want, is to block the Cox2 enzyme and to reduce the inflammation. But Cox2 can also be constitutive, and it's constitutive in the brain and in the kidney. And so the inhibition of Cox2 will reduce the inflammation. We also reduce the pain and fever, but then you have some adverse effects that are related to the Cox enzyme in the kidney. And so for the Cox1, the inhibition of Cox1 is the cause actually of the gastric ulceration and the GI bleed. Is because Cox1 is constitutive in the GI tract, and also supports the platelet activation. So if you block it, you have a higher risk of bleeding, and so that's where you see the adverse effect of those drugs. So here is again the mechanism of action of those NSAIDs. So as I said, they are the COX enzyme are involved in the synthesis of the prostaglandins and their other compound. So COX1 is constitutive in the GI mucosa and is also important for the platelet aggregation. So if you inhibit this effect, then you inhibit the platelet aggregation, and you also block the protection of the GI mucosa. So this would be the adverse effect of the NSAID. And then COX2, which is responsible for inflammation. So if you block this pathway, then you can reduce the inflammation. So let's first talk about the first generation of NSAIDs. And so the first generation, the oldest generation, they are the non-selective Cox inhibitors, and the most commonly known one is aspirin, so acetylsalicylic acid. We talk about this in the anti-platelet lecture last quarter, and so if you remember, aspirin is a irreversible Cox1 and 2 inhibitors. So irreversible, it block the activity of the Cox enzyme irreversibly. And so the platelet that has aspirin that inactivate the Cox enzyme, you need to have a new platelet with fresh enzyme. But of course, you don't have all the enzymes that are inhibited at once within the platelet. But in order to have the action of the Cox functioning again, you have to wait for the life span of the platelet. Now, aspirin, has different property depending on the dose, and so low dose is the one that is anti-aggregant, and so we still don't know what is the exact dose for against thrombotic disorder, but it's around 75 to 100 milligram versus for the analgesic effect. You see, it's a much, much higher dose, 325 to 650 milligrams. Same thing for reducing the fever, it's a higher dose than for the treatment of thrombotic disorder for the anti-platelet effect. Now, the adverse effect, as I said, because it's non-selective and can inhibit both COX-1 and COX-2, that's why you have more adverse effects with those older generation of NSAID. Can cause GI adverse effect, heartburn, nausea, and then ulceration. Can also cause bleeding because of the anti-aggregant property, renal impairment, and then Reye syndrome. So this is a potentially fatal disease that causes numerous detrimental effects, especially in the brain and the liver. And this is seen in children who has either chickenpox or influenza, and so you see you have a fulminant hepatitis, and then you have cerebral edema. And so this is why you have to avoid aspirin in children that are younger than 16 years old. Now, drug interaction, of course, because of the anti-aggregant property, there is a higher risk of bleeding when it's associated with warfarin or other NSAID like ibuprofen. If you have two drugs that has the same property, you have a higher risk of having combination of adverse effect. Also with glucocorticoid and alcohol. No poisoning because it's an acid that would cause acidosis and then would lead to hyperthermia, sweating, dehydration, and then ultimately respiratory failure. The treatment of aspirin poisoning is cooling, IV bicarbonate, because aspirin is an acid. By giving the bicarbonate, you will reverse the acidosis and also accelerate the excretion. If you remember your pH partitioning, if you increase the pH of if you actually make your pH more basic, then it will increase the excretion of your acidic drug. Now, other first generation of NSAID, you have ibuprofen, very common, like Motrin, Advil, over the counter, it's 200 milligram. So this is the prototype. It's superior for dysmenorrhea, so pain caused by menstrual cycle, by periods. But it's very effective for mild pain or fever. There is an increased risk of MI and stroke because of the effect on also on the anti-aggregant property, the risk of bleeding. And then naproxen, Aleve. The higher dose of naproxen, you need a prescription. 220 milligram is over the counter, but naproxen, so above 250, it's prescribed drug. Indomethacin is a prescribed medication. Ketorolac and meloxicam are both first generation non-selective and prescription NSAID. Ketorolac is a very powerful analgesic that you will probably see in acute care setting. But it's used for postoperative pain and it's as effective as morphine sulfate. Meloxicam has some COX2 selectivity, so was thought to be a little bit less causing less GI adverse effect, but overall it doesn't really seem to be that way. Also depending, on the duration of the use of those medication, and especially for those who are using it for arthritis, which is a long-term chronic use where you can still see some GI adverse effect. No, all NSAIDs, even the over-the-counter one. You can look at your aspirin, ibuprofen. You will see that there is a black box warning with increased risk of cardiovascular thrombotic event and increased risk of serious GI bleed. It's because they are non-selective Cox inhibitor. Now, the Cox2 inhibitors, even though there is only one that is still approved, it's celecoxib, Celebrex, lower GI toxicity in short studies, but for a patient again who has rheumatoid arthritis, are using in long term, after 12 months, there is not really a difference in the GI toxicity, but it's a selective Cox2 inhibitor. It has analgesic and anti-inflammatory property. You also have less risk of cardiovascular disease than the older one. And so actually the older ones, such as rofecoxib, Vioxx, and valdecoxib, they were removed from the market because of the increased risk of MI and stroke. And one thing you have to be careful with those medications is that can cause it's a patient with chronic kidney disease because it can impair the renal function since COX2 is constitutive in the kidney. So if you block the activity of COX2, you have a risk of renal impairment. No, acetaminophen, your Tylenol, but it's also, there are also like 600 other products that contain aminofen. So you have Tylenol that is pure acetaminophen, then you have all the generic form, all the pharmacy form, but also acetaminophen is, used in your Dayquil, NyQuil, Vicodin, Percocet. It's, in many combination drugs, so there are more than 600 products that contain acetaminophen. Mechanism of action in terms of analgesia is not fully understood. Maybe there is some COX2 inhibition in the central nervous system. One thing you have to know is like acetaminophen is not an anti-inflammatory drug nor an antiplatelet agent. So it doesn't cause any gastric ulceration. So someone who is in pain, like mild pain to moderate and have, sensitive GI tract or has heartburn, acetaminophen would be a better medication for them. The acetaminophen is analgesic and antipyretic, so can treat fever. It's the drug of choice in pregnancy. Now, the main concern is the chronic hepatic effect, and this can be seen with the use of 4 grams a day for 14 days. So again, if it's someone like a student who has a headache after studying for pharm and take 1 tablet or 2 tablets or even 4 tablets in a day for several days, not going to be a concern of chronic hepatitis, chronic hepatic effect. But again, for patients who are on chronic pain and are using like different agents to manage their pain, this may be a concern. And so to help encourage the safe use of acetaminophen, actually the manufacturer of Tylenol, they have lowered the daily dose so the extra strength is 500 milligrams of Tylenol, and now they reduce it from 8 pills per day to 6 pills per day. And the dosing interval has also been changed from 2 pills every 4 to 6 hours, and it was moved to 2 pills every 6 hours. So the goal is to be below 3 grams per day for those who really need to be on a high dose of Tylenol. Most of the patient who need Tylenol for a headache or a cold, they would use maybe max 2 grams per day for several days, but they will not use Tylenol for such a long period of time. Now, in case of overdose, somebody is really, really like using, and what can happen also is like, so of course you have Tylenol and, Tylenol or other like generic brand, the dosing, but what patients sometimes tend to forget is like a lot of other product contain acetaminophen. As I said, Dayquil, NyQuil, or Percocet, and then they don't really understand, and then they would take their Dayquil plus their Tylenol and plus maybe something else, and so that can add up, and that's why you can sometimes fall into an overdose situation, which cause severe serious liver injury, especially in heavy alcohol users, because that will by induction of the enzyme that make the toxic intermediates, and that cause the liver toxicity. And so in case of overdose, you can use acetylcysteine, which is mucomist, and that will actually chelate those toxic intermediate and restore the hepatic function, and restore those enzymes that are necessary to inactivate the toxic metabolites.